I heard the words, you have breast cancer. But let me tell you, at that point, when you are diagnosed, your brain explodes and you don't want any choices.
Welcome to Breast Cancer Breakthroughs. You just heard from Michelle Beck, a two-time breast cancer survivor. Did you know that 65% of breast cancers are diagnosed at the local stage, or when the tumor is only found in the breast? People like Michelle, who face an early breast cancer diagnosis, are immediately saddled with many decisions that they need to make about their care. And some of these important decisions are about managing your risk of recurrence. A major goal of treatment for many people with early breast cancer is preventing recurrence for as many people as possible to save lives. We need the best tools and treatments available to understand each person's risk for recurrence and effectively manage it. In today's episode of Breast Cancer Breakthroughs, you'll hear more from Michelle about how she navigated her risk of recurrence and her treatment options. You'll also hear from experts on breast cancer recurrence, Dr. Angela DeMichele and Dr. Ruth O'Regan, who will help explain what recurrence is and what tools doctors have available to help understand a person's risk of recurrence. To learn more about breast cancer recurrence, check out our linked video below. Recurrence is a word that we hear frequently when we hear about breast cancer. But what does recurrence mean? Recurrence is when breast cancer comes back after a person has completed their initial breast cancer treatment. We asked Dr. Angela DeMichele to tell us more about breast cancer recurrence.
In general, recurrence refers to the process by which breast cancer cells can leave the breast and travel to another part of the body where they can grow. So a recurrence can actually happen within the breast where the cancer started, or it can happen locally. By that we mean in the chest or in the lymph nodes that surround the breast, particularly the lymph nodes that are under the arm. Or it can be a distant recurrence. And by that we mean breast cancer cells that have traveled to other parts of the body outside of the breast and lymph nodes, for example, the lungs or the liver or the bones. So those are all different kinds of recurrences, and those recurrences each have their own way of being treated, and they have different implications for prognosis. We have only recently started to understand how recurrence happens. For decades, it really was sort of a black box. We knew that women would get tumors in the breast, and we could even find the cells under the arm. And even though we would remove the tumor from all the places we could see, it would come back years or even decades later in other parts of the body. And how it managed to get to those other parts of the body was really a mystery until somewhat recently. We're now starting to understand that there are specialized cells within breast tumors, very rare cells, that have the ability to leave the breast. And we think that these cells enter the bloodstream, and they can either immediately find their way to another place, or they can enter what's called a dormant or sleeping phase, where the cells burrow into a specific area. Often this is the bone marrow, and the cells actually go to sleep. They stop dividing, they stop growing, sort of like a bear hibernating in a cave for the winter. They shut down for some period of time. Then, for reasons that still are not entirely clear, the cells can wake up, they can start dividing and growing again. They leave that niche where they have been protected, go back into the bloodstream, and travel to another part of the body.
Like most aspects of breast cancer and breast cancer treatment, the risk of experiencing a breast cancer recurrence is not one size fits all. Dr. DeMichele explained to us how the risk of recurrence can vary from patient to patient, and she told us a little bit about the tools that doctors use to help predict a patient's risk of recurrence.
The risk of recurrence is different for different types of breast cancer. So triple negative breast cancer, those cancers that don't have estrogen or progesterone receptors and don't have HER2 receptors, those tumors tend to send out cells that will come back within the first 5 years of the cancer's discovery. And so even though those cells may have a dormant phase, it's very short. It's very similar for HER2 overexpressing tumors. Estrogen receptor positive breast cancers, however, seem to be fundamentally different. They can have a very long dormant phase, and they can then come back 10, 20, 30 years later. So we do really think about these different types of breast cancer as having different trajectories. And even though the process of recurrence is the same, it plays out differently depending on the type of breast cancer a patient has, and the time frames can be very different. Traditionally, we have used factors like the size of the tumor, whether or not there are lymph nodes involved and how many, and then more recently using genomic tests like the Oncotype recurrence score or MammaPrint or breast cancer index. These are tests that look at the genes in the tumor, and based on the pattern of which genes are turned on and turned off, we can estimate the likelihood that there are cells that escape from the tumor and that have a possibility of coming back later. I think that what's also important here is eventually we will get to the point where we can test people and determine that they're not at risk of recurrence. We've never really had a way to tell someone that they will never recur. So every single patient worries about this, regardless of how low the risk is. We never can tell them it's zero. So I hope that in my lifetime, we'll reach a point where we actually know how to use these tests to tell us both who's currently at risk and who's never going to be at risk, and really remove that burden from patients' shoulders that they carry lifelong.
Dr. DeMichele also explained that oncologists work closely with their patients to tailor their treatments to help them best prevent recurrence and maintain a good quality of life while on treatment.
Really trying to understand the magnitude of the risk factors really strongly into the decisions we make about which treatments we'll give. And as an oncologist, I spend a lot of time speaking with my patients about their level of risk and what I can recommend as enough treatment to have a good chance of eliminating the cells, but not so much treatment that they're going to be left with lifelong side effects. So really, we are always trying to figure out, based on the level of risk, how little treatment we can safely get away with to give patients the maximal amount of insurance against a recurrence. But we also are weighing that against the side effects that can come from these treatments. So the lower the risk, and particularly in very low risk patients, it could be very little extra treatment. It could just be surgery and radiation, or just the addition of an anti-estrogen pill and no chemotherapy. Whereas on the higher risk side, we start adding more intensive treatments, more chemotherapy, CDK4/6 inhibitors, and other things. So we are really trying to tailor the insurance against recurrence to the level of risk the patient has.
As we heard from Dr. DeMichele, some patients, particularly those with very early stage breast cancer, have options to manage their risk of recurrence. Michelle Beck was one of those patients.
I started doing mammograms at age 37. And on my fourth one at age 41, I got that dreaded call where I had to go back. And then a few days later, on December 7th, I heard the words, "You have breast cancer." So that date will forever live in infamy for me. I am very lucky. I was diagnosed early, thankful to my mammogram, stage 1, grade 1, ERPR positive, HER2 negative, quote unquote, the best kind of breast cancer, even though it is all really horrible. But I was very fortunate in the fact that I had choices. But let me tell you, at that point, when you are diagnosed, your brain explodes and you don't want any choices. I did at that time go ahead and choose to have a lumpectomy with radiation. And then I did 4 years of tamoxifen, kind of put it behind me. I had a young son at the time. I was very busy with my family. And lo and behold, 4.5 years later, I was diagnosed in my other breast. So I had a new primary occurrence in my other breast.
As someone who has been diagnosed with early breast cancer twice, Michelle has had to face several different crossroads where she's had to weigh the risks and the benefits. She shared with us some of the most difficult decisions that she had to make during her breast cancer journey.
I was debating getting genetic testing, the BRCA test, because at the time I was diagnosed in 2012, it was so expensive and a lot of insurances did not cover it. However, since I had a family history, we decided, yes, to go ahead and get the testing done because I was still really unsure of what I was going to do treatment wise. I did find out that I am BRCA negative. And then when I got those results back, I had to actually make a decision about my treatment plan. I was really not that I was hoping to be BRCA positive, but I wanted someone to make the decision for me because when you first hear those words, literally rational thought goes out the window. And having someone to help or something to help with those decisions is life changing. So I did finally opt to have a lumpectomy and radiation because at the time my son was not even 2 years old. And I'd waited a long time to be a mom and I wanted to just kind of get treatment over with and move on. I was told that my survival rates were the same, whether I went with lumpectomy versus mastectomy. And that seemed like a pretty good news to me. So I went the easier route. Looking back on it now, it might have been a change that I would have made if I knew I was going to be diagnosed in my other breast. But at the time, that decision was right for me. But it was really hard to make. One other hard decision I had to make was after my second diagnosis, they gave me an oncotype test, which I did not have that the first time around. But with the mastectomy that I did, both sides, removing my ovaries, which gave the dreaded estrogen, I felt comfortable and confident in that decision that I wanted to forego chemo because honestly, I was scared. I didn't want to go through chemotherapy if I didn't need to. And my doctor was very on the fence. I worked with my doctor on all of these major decisions, and that one was left up to me. And then the next biggest decision was how long do I need to continue on the aromatase inhibitors?
Michelle was taking aromatase inhibitors after her second diagnosis, but she suffered debilitating side effects from them. She explained to us how she worked with her doctor to determine how she could best manage her risk of recurrence while still maintaining a good quality of life.
The worst for me was the joint pain. My knees, my hips. I would have pain in my hands and my feet, like the palms, and they would just ache and throb. I would be sitting at night just rubbing my hands together, trying to do anything to stop the pain. I couldn't even walk my dogs down the street because it hurt. And I cannot express the lack of quality of life I was having due to the hormone medication. So I found the breast cancer index test on Instagram and I saw this come up in my feed and I met the parameters and it was like, do you need more hormone therapy? I'm like, in my brain, I'm like, God, no, I do not need any more of this hormone therapy. And I met the parameters. So I had gone in to meet with my doctor because I wanted testing. So we ordered it and I waited on pins and needles and I did research and it's super easy because they just go back to the hospital, find whatever little tumor sample they have from your biopsy and they get it in, get you the results. And I was anxiously awaiting the results. I'm like, "Oh, please tell me, please tell me." And when I got them, I sobbed in sheer relief.
The results from her breast cancer index test showed that Michelle only had a low risk of recurrence at just 2.9%. And after discussing these results with her doctor, they decided together to discontinue aromatase inhibitor treatment. The breast cancer index test is one of several tumor profiling tests that are available to predict a person's risk of recurrence for those with early breast cancer. They are all prognostic, which means that they provide an estimate of the likelihood of breast cancer recurring. But some tests are predictive, meaning the results of the test indicate the course of treatment that is best for the patient. Dr. Ruth O'Regan has been involved with some of the studies on the breast cancer index test. She explained to us the gap that this test fills for patients and the role that it plays in helping patients and their doctors tailor their treatments.
So the breast cancer index test is a test that uses tissue from a patient's original surgical specimen and biopsy And it looks at the genes that are driving, or specific genes that the expression of specific genes within a patient's tumor. So it's a combination of 5 genes that are associated with how rapidly cancer cells grow, and 2 other genes named HOXB12 or H, or IL-17BR, or IL, which is known as the H over I index. And what the expression of these genes tells us is, first of all, how likely it is that a patient's tumor will recur after 5 years since diagnosis, but also it helps us to decide whether further endocrine therapy might be of benefit to an individual patient to prevent the cancer recurring. So based on an older study, what we've traditionally done is used 5 years of endocrine therapy. But one of the questions out there is, are there patients that actually need more chronic therapy, or certainly given for 10 years? So there's been a number of trials that have compared 10 years of endocrine therapy with 5 years. And in general, they've shown some benefit overall in extending therapy for 10 years, but it really varies from patient to patient. So the breast cancer index, basically by measuring the expression of these 5 genes associated with how quickly the cells multiply, and the H over I index, actually tells us, firstly, what the likelihood is that a patient's cancer is going to recur beyond 5 years. But secondly, the H over I index component actually tells us whether a patient might benefit from extended hormone therapy. So rather than just telling everybody they need 10 years of treatment, this tells us, the results of this test tells us which patients can actually stop at 5 years. So in other words, you're basically tailoring the duration of therapy to the patient's individual breast cancer.
Since there are many tumor profiling tests available, Dr. O'Regan also explained to us how the breast cancer index test is different from other tumor profiling tests.
There's a number of what we call genomic assays used in treating breast cancer patients. So there's several tests that are used up front to determine what the benefit an individual patient will get from adjuvant chemotherapy. The breast cancer index is a little bit different because the H over I part of it is really associated specifically with estrogen receptor signaling. So it is a test that tells us what benefit patients are going to have from endocrine therapy. So although the other assays have been used to predict what an individual patient's risk of recurrence is after 5 years, they've never been shown to actually show which patients actually need more endocrine therapy. So breast cancer index is currently the only one in the breast cancer treatment guidelines that actually is used to predict the benefit of continuing endocrine therapy beyond 5 years. And that's really where it's different from the other genomic assays that we have.
To learn more about how tumor profiling tests work, check out our video linked below. There is a new registry study underway to further validate the test in 3,000 more patients. Through this study, researchers are hoping to confirm that the test effectively predicts the benefit of extended hormone therapy and to gain some insight into how the test impacts treatment decisions. New data from this trial has shown that treatment decisions changed for 40% of the patients after receiving results from the test, with the majority stopping their hormone therapy earlier than originally planned. Having more tools at our disposal, such as the breast cancer index test, can help us make data-driven decisions about treatment. These sentiments were echoed by Michelle Beck.
I love all the test results because, as I mentioned earlier, making these decisions once you have a breast cancer diagnosis is impossible. As I mentioned, I've done genetic testing, I've done the oncotype test, and the breast cancer index test was the one that had the biggest impact on my life because I really do feel like it gave me my life back. So having these tests out there is critical so we can make those choices because there are people who are farther along in their cancer diagnosis or journey where their decisions are like made for them because yes, you have stage 3, you have a 4-inch tumor, there are things that you need to do by standard of care. But for many people like me, where I have a lot of options, we really don't want the options. I want to be able to take have confidence in tests that are out there so I can really make the best decision for myself and the rest of my life.
Thank you all so much for watching. We hope you've come away feeling empowered to work with your doctor and make decisions based on your own personal risk of recurrence. Here at Komen, we are committed to bringing you evidence-based information to empower you on your journey with breast cancer. Don't forget to sign up for reminders for breast cancer breakthroughs. We've linked to the homepage below. And finally, if you liked today's episode, please take 2 minutes to fill out our short survey, linked below in our description.